I'd request you to stand over there and continue with your next talk on treatment modalities in CSCR.
So this is my second talk on treatment modalities for CSCR. So with new updates in its management, several treatment modalities have come up being tailored for CSCR patients. As you all know, acute CSCR, we usually observe the patients hoping that it will obviously spontaneously resolve. Should observation fail, the possible treatment modalities include focal laser, sub-threshold micropulse laser, photodynamic therapy, or even oral medications. So chronic CSCR is associated with persistent disruption in vision. Half-dose PDT is the single most effective treatment for CSCR, but unfortunately it's not available. The dye is not available in our country. Observation is usually recommended as a first-line treatment for acute CSCR. About 90 to 95% cases are typically self-limiting with spontaneous resolution of subretinal fluid. Interventions may be needed if the subretinal fluid is persisting for a duration of more than 3 to 4 months, if there is multiple recurrences, or if the patient wishes to have a slightly earlier recovery of vision. So this is a case of acute CSCR in which there is a clear subretinal fluid, OCT, otherwise it's not showing any changes, and after just 1 month of observation, the fluid is completely resolved, giving a dry section at the macula. Observation without additional treatment within the first 3 months might be the preferred approach in most centers. The gradual resolution of neurosensory detachment can be observed from monitoring the patient from time to time. Visual recovery can also be enhanced by counseling the patient on modifying the risk factors. For example, cut down on smoking if he's a smoker, reduce the stress levels if he's taking steroids, to discontinue the risk factor of using exogenous steroids, etc. Even doing light activities, yoga, meditation, etc. helps in sort of resolving these acute CSCR cases. So managing a case of chronic CSCR becomes problematic. You need to look for the risk factors. Age is a factor again. Perform FFA and IC78 to reach a conclusive diagnosis for presence of leak points. Extrafoveal leaks should be treated with focal laser. Subfoveal leaks need to treat with low fluence photodynamic therapy or micropulse. If there's absence of leak, you need to observe the patients, and you can also try a course of oral medications. If there's no response, perform an ICGA and go for a low fluence PDT or micropulse. So focal laser photocoagulation over here, low intensity, that's level 1 retinal tissue reaction, short exposure with 50 micron laser burns are the common exposure parameters. Thermal laser directly applied to focal sites of RP leakage, which are usually seen only on FFA. And mechanism of action of this laser is not completely understood, but is believed to seal the leakage sites to photocoagulate the cluster of diseased RP cells. It also activates the retinal pigment epithelial pump by redirecting the fluid back into the choriocapillaries. So this treatment is effective for both acute and chronic cases. So some of the acute cases cannot be treated by laser photocoagulation because the leak points are very close or even within the fovea. So laser can only be applied if the leakage point is located at least more than 400 micron from the foveal center. Photodynamic therapy involves utilizing a bisudine dye, that is vertiporphin, and it uses laser light of 89 nanometers. With a fluence of around, this is a full fluence like 50, and half fluence is 25. And it's used to treat both acute and chronic CSCR cases and also reduces the vascular hyperpermeability. So PDT works by stopping the abnormal leakages, allowing for absorption of SRF, and reduces the choroidal hyperpermeability. And during this process, free radicals are released when the vertiporphin dye is activated to restore the damaged choroidal vessels and vessels the RPE. As I said, vertiporphin can either be administered full or half dose. The most common complication seen following PDT treatment is secondary CNVM development. So in order to minimize the occurrence of these complications, new treatment modalities using 1/3 the conventional dose. The conventional dose is 6 milligram. Even 1/3 dose using 2 milligrams have been tried in various studies with good effects. So this is a table which shows various studies which have been done using the various different dosages as well as fluence of PDT. And in most of these studies, we see that using half-dose PDT itself is enough to have a substantial reduction in subretinal fluid as well as good improvement in visual acuity. So subthreshold micropulse laser, it uses subthreshold energy in a burst of micropulse. It selectively targets the retinal pigment epithelium without leaving much residual damage to the retina. The duty cycle commonly employed is in the range of 5 to 10%. There are several wavelengths of laser which is used to target different cells in the retina, such as green, yellow, and infrared, as you know. So the subthreshold micropulse is relatively safe to apply close to the fovea, as it is poorly absorbed by the macular xanthophyll pigments. So here's a case example of a 56-year-old female who complained of diminution of vision of both eyes, who had a best corrected vision of 6/18 and 18. On fundus photography, you see an area of serous macular detachment both in the right as well as left eye. OCT of the right eye shows subretinal fluid, whereas the left eye shows subretinal fluid with a small CLS PED. On fundus fluorescent angiography in the right eye, you get extrafoveal, small point leak extrafoveally, and a very subtle leak, if at all you can call it a leak, as seen just above the foveal avascular zone. In the left eye, you get a more obvious extrafoveal leak towards the late phases. So over here, this patient received focal laser multiple times, and every time the patient came with reduction and recurrences. So it recurred around 3 times. So this was the follow-up. At each visit, the patient had an FFA done. So this is a sequential follow-up over a course of almost 10 months, in which the initial subretinal fluid is reducing in subsequent visits, but new leak points are developing extrafoveally. So that's why you can see an extrafoveal subretinal fluid developing over here, although the foveal subretinal fluid is reducing. The patient is maintaining almost a stable vision of 6, 18, and 10. This is the left eye. Again, the sequential follow-up shows reduction in subretinal fluid over a period of 10 months. So this is multifocal CSR cases are a little difficult to manage. This is an ICG which gives area of hyperpermeability of the choroid, and also helps in directing photodynamic therapy guided treatments. So this patient underwent full dose half fluence photodynamic therapy, and you can see how beautifully the subretinal fluid has resolved actually, and the patient attained a final vision of 6/12 N6 in the right eye, and left eye again 6/6 N6. You can barely say that the patient had an episode of CSCR in this eye. So anti-VEGF agents again have been tried in cases of CSCR complicated by neovascularization. I do not advise you to directly jump into an anti-VEGF agent when treating CSCR patients. Studies have obviously varied in what they infer from these by using these anti-VEGF agents. So this is one of the patients who I saw 3 months back. He's a patient from UAE. You can see an area of subretinal lesion at the macula. The FFA shows a leak exactly just at the fovea. On SDOCT, along with subretinal fluid, you can see a subretinal hyperreflective material, and along with the PED. So it looks like a fibrinous element of CSCR. The patient underwent micropulse laser because the leak was exactly almost touching the foveal avascular zone. As you can compare, the subretinal fluid is slightly reducing. Even the subretinal hyperreflective material is also reducing. But patients called me up and said the vision is not improved significantly. So I went ahead with the ranibizumab injection by calling him again for a follow-up. And after this, patient attained the vision of 6/6 parts from vision of 6/18. So you can see how well sometimes in these cases anti-VEGF injections work. The other pharmacodynamic therapies include topical NSAID agents like Nepalac, which we commonly give in these patients, hoping that it has some placebo effect. And carbonic anhydrase inhibitors such as dorzolamide also helps in improving the absorption of SRF. Oral medications have also been tried in the form of eplerenone, spironolactone, etc., about which Jyoti sir will be also talking about on the pharmacotherapy of CSCR. But again, without much of literature regarding these oral medications. Thank you.
Thanks, Dr. Kiran, for the